let's start today with a specific image. I want you to picture a 59-year-old woman sitting in an exam room. Let's call her Mrs. G. She is visibly uncomfortable, shifting in her chair, maybe holding her lower back. She tells you she's been dealing with frequent painful urination for about 4 days. Standard UTI symptoms, right? But then the story shifts. She says, "Doctor, for the last 2 days I've had fevers, chills, and this deep ache in my side." And she points right to her clink.
And right there, the whole clinical picture just changes completely. We're
Yeah.
not looking at a simple cystitis, a bladder infection anymore.
Not at all.
That flank pain and the fever, those are the hallmarks of pyelonephritis. The infection has ascended the ureters and is now invading the kidney tissue itself. The stakes just went from, uncomfortable to potentially systemic.
Exactly. And the plot thickens when you open her chart. Mrs. G has a history of recurrent infections, 3 in the last year alone. Every single time she was treated with trimethoprim, sulfamethoxazole, and every time it seemed to clear up.
Seemed to, yeah.
But here she is again, and there's one seemingly minor detail in her medication list. She has osteoporosis, so she takes a high-dose calcium supplement every morning with her breakfast.
And it sounds like such a minor detail, but in pharmacology, those minor details are often exactly where treatment failure happens. Mrs. G represents a classic, a really high-stakes puzzle.
I'll say puzzle is a good word for it.
Yeah. You have recurrence, which immediately makes you think about bacterial resistance. You have organ involvement, the kidney, which demands excellent tissue penetration. And then you have that supplement, the calcium, that can act like a chemical saboteur if you pick the wrong antibiotic class.
It's a minefield. And that tension navigating the minefield of resistance and tissue targets and drug interactions is really the core of our deep dive today. We're exploring broad-spectrum decisions. We aren't just memorizing drug names. We are synthesizing the heavy-hitting concepts from Katzung's chapter on sulfonamides, trimethoprim, and quinolones, and its counterpart in Goodman and Gilman.
Right. And the mission here is to understand the trade-offs. We're looking at sulfonamides, trimethoprim, and quinolones. These are, they are powerful, versatile drugs, but they absolutely come with costs.
Yeah.
Our goal is to move beyond that pill for every ill mentality and to understand these drugs as interventions in a complex living system.
So for you, the listener, here's the roadmap. By the end of this hour, you are going to understand the mechanism of sequential blockade, essentially how 1 + 1 = 3 when we sabotage bacterial metabolism.
We're also going to help you visualize the structural mechanics of DNA gyrase inhibition, how you can physically freeze bacterial DNA in its tracks.
And we're going to do the math on pharmacokinetics. We need to explain why the dosing ratio for TMP-SMZ is 1:5, but the ratio in the blood is 1:20, and why that math is the difference between the bacteria living or dying.
And critically, we'll look at how the local environment of the infection, specifically acidity, changes the rules of engagement, especially with some of the newer agents like delafloxacin.
So let's go back to Mrs. G. She's in pain. We have to treat her. Her history says trimethoprim sulfamethoxazole worked before, so why shouldn't we just use it again?
Well, to answer that, we have to understand what that drug actually is.
Oh.
Let's talk about the antifolates.
Okay, the antifolates.
To really get the antifolates, you have to understand the supply chain of a bacterial cell. Think of a bacterium as a rapidly expanding factory. Its number one goal is to duplicate itself.
Right.
And to do that, it needs to manufacture DNA. And a critical raw material for making that DNA, specifically the purines, the A's and G's, is folate.
Folate is the fuel for the DNA printer. I had a salad for lunch, so I've got plenty of folate floating around in my system. I just absorbed it from my diet.
Exactly. And that is the fundamental biological difference that allows these drugs to even exist. Humans are auxotrophs for folate. We have to eat it. We have a transport system to pull it into our cells from our blood. Most bacteria, however, they lack that transport system. They are, for the most part, impermeable to dietary folate. They're sort of stranded on an island. If they want folate, they have to build it from scratch, molecule by molecule.
So they have their own internal assembly line.
An assembly line is the perfect analogy. And the starting material for that assembly line is a small molecule called para-aminobenzoic acid, or PABA.
PABA. Okay. So the bacteria takes PABA and it feeds it into the first machine on the line.
And that first machine, the first enzyme, is called dihydroxyurate synthase. It takes PABA and it links it up with other molecules to start building the basic folate structure. This is where the sulfonamides come in.
This is the first act of sabotage.
The first sabotage. Sulfonamides are what we call structural analogs of PABA. If you were to look at their chemical structures side by side, they are geometrically almost identical to PABA. They're a decoy. A very, very good decoy.
So the enzyme dihydroapatite synthase is reaching out to grab a molecule of PABA, but it grabs the sulfonamide instead.
It's classic competitive inhibition. The enzyme is strict. It grabs the sulfonamide and tries to force it into the reaction. But of course, the sulfonamide doesn't fit the catalytic mechanism. It's like breaking a key off in a lock.
Ah.
The enzyme is now occupied, it's jammed, and it can't process the real PE that's floating around.
And if that first step is blocked, the whole assembly line just grinds to a halt. No folate gets produced.
Correct. But here is the critical nuance. Sulfonamides alone are usually only bacteriostatic.
Bacteriostatic, meaning they stop the bacteria from growing but don't kill them.
Exactly. They stop them from growing and dividing, but they don't necessarily kill them outright. The bacteria might just sit there, dormant, waiting for the drug to wash away. Or, and this is a key resistance mechanism, they might just scavenge enough PB to overwhelm the inhibitor.
Which is why we rarely see sulfonamides used as a solo therapy these days, right? Resistance is just too easy to develop.
Way too easy. The bacteria just ramp up their PB production, they flood the system, and they effectively push the decoy out of the way through sheer numbers.
So we need a second strike.
We need a second strike. We need to hit the assembly line at a downstream point to guarantee total failure. And this is where trimethoprim enters the picture.
Okay, so trimethoprim targets the next machine in the line, right?
Yes. The enzyme is called dihydrofolate reductase, or DHFR. This enzyme's job is to take the precursor, which is dihydrofolic acid, and perform a final reduction step to create the active form, tetrahydrofolic acid.
And that active form is what actually does the work.
That's the one that donates the carbon atoms to build DNA precursors. It's the final usable product.
So sulfonamides jam the first door. If any material manages to sneak through that first blockade, trimethoprim is waiting at the second door to smash it.
That's a perfect way to put it. And this brings us to a really critical concept in pharmacology: selectivity.
Right.
You mentioned earlier that humans use folate. We also have dihydrofolate reductase to process that folate. So why doesn't trimethoprim poison us?
That's the billion-dollar question. If we're blocking the enzyme, aren't we blocking our enzyme too?
We are, but only very, very slightly. It turns out that the bacterial version of DHFR and the human version of DHFR have significant structural differences at the molecular level.
Ah, okay.
Trimethoprim binds to the bacterial enzyme with an affinity that is about 50,000 times higher than its affinity for the human enzyme.
50,000 times. That is a massive margin of safety.
It's an incredible margin of safety. It's a beautiful example of molecular precision. It fits the bacterial lock perfectly, but barely even interacts with the human lock.
So now we combine them. Sulfamethoxazole blocking step 1, trimethoprim blocking step 2, and this is what we call sequential blockade.
And the result is synergy. Synergy is one of those words that gets, overused in business, but in pharmacology, it has a strict mathematical definition.
Right.
The effect of the combination is significantly greater than the sum of the two individual effects.
The classic 1 + 1 = 3.
Or in this case, maybe 1 + 1 = 10. By blocking two distinct steps in the same critical pathway, we convert a bacteriostatic intervention into a bactericidal one.
Ah, there it is.
We don't just stop growth, we induce cell death. Because the bacteria completely runs out of the cofactors needed to maintain its DNA, it essentially starves to death metabolically.
So let's apply this to the spectrum of activity. We have this powerful combination weapon. What can it hit?
It's incredibly broad. It covers a lot of gram-positives like Staphylococcus aureus, and that includes many strains of CA-MRSA, the community-associated methicillin-resistant Staph aureus.
Which is huge.
It's huge. And it hits a wide range of gram-negatives: E. coli, Klebsiella, Salmonella, Shigella.
Which explains why it's been the workhorse for UTIs and gut infections for decades.
For decades. But it goes beyond bacteria. Because that folate pathway is so ancient and conserved across many organisms, TMP-SMZ is also effective against protozoa, like Toxoplasma gondii.
The cat litter parasite.
Yes. And even some fungi, most importantly, Pneumocystis jirovicii.
Pneumocystis. That's the big one for immunocompromised patients, right?
It is the defining opportunistic infection for patients with AIDS. TMP-SMZ is the absolute drug of choice for both treatment and prophylaxis of what we call PCP pneumonia.
But no drug is perfect. What's the Achilles heel here? What does this combination miss?
The big gaping hole in its spectrum is Pseudomonas aeruginosa.
Okay.
Pseudomonas is a tough, hardy organism. You often find it in hospitals, in ventilated patients. It is intrinsically resistant to this combination. So if Mrs. G had, say, a hospital-acquired infection or if she had distinct risk factors for Pseudomonas, TMP-SMZ would be completely useless.
Okay, so we've established the power of this sequential blockade. Now I want to get into the precision, and specifically the math you mentioned. You said in the intro that the pill is a 1-to-5 ratio, 80 milligrams of trimethoprim, 400 milligrams of sulfamethoxazole. Why that specific recipe?
This is such a great question, and it's a favorite for board exams because it really gets at understanding pharmacokinetics,
Right.
or PK. The goal, the therapeutic target, is to achieve a ratio of roughly 1 to 20 in the serum in the blood, because that is the ratio where the optimal bacterial killing happens.
So wait, we want 1 part trimethoprim to 20 parts sulfamethoxazole circulating in the blood, but we feed the patient 1 part to 5 parts. How does the body distort the ratio that much?
It all comes down to a concept called the volume of distribution, or VGAID. Imagine the body as a set of interconnected buckets. You have the blood bucket, which is relatively small, and you have the tissue and fat bucket, which is huge.
Okay, I'm visualizing the buckets.
Sulfamethoxazole is a drug that, for the most part, likes to stay in the blood bucket. It has a low volume of distribution, about 0.2 liters per kilogram. It binds to proteins in the blood like albumin, and it just kind of stays there, circulating.
So it's trapped on the highway system, so to speak.
Pretty much. Trimethoprim, however, is highly lipophilic. It loves fat. It has a huge volume of distribution, something like 1.5 to 1.8 liters per kilogram.
So it's much bigger.
Much, much bigger. So when you swallow trimethoprim, it gets absorbed, enters the blood, and then immediately pours out of the blood bucket and soaks into that big tissue bucket.
So if you gave them in a 1-to-1 ratio, the trimethoprim would just vanish into the tissues, leaving the sulfamethoxazole all by itself in the blood. You'd lose the synergy.
You'd lose the synergy entirely.
Oh,
the
right.
ratio in the blood would be way off. So we have to overload the sulfamethoxazole input by a factor of 5 to compensate for the fact that trimethoprim is going to run away and hide in the tissues.
Wow.
By dosing it at 1 to 5, the differing distribution rates balance each other out, and what's left circulating in the plasma ends up being that magic 1 to 20 ratio.
That is such a cool example of using math to hack biology. But speaking of that tissue bucket, this brings up a huge clinical advantage, doesn't it? Maybe not for Mrs. G, but for a male patient.
It absolutely does, because trimethoprim leaves the blood so readily it concentrates in tissues. But there is a specific, very elegant mechanism called ion trapping, or the acid trap, that is crucial here.
Ion trapping? That sounds like physics class.
It is basic physics and chemistry. Trimethoprim is a weak base. Basic chemistry tells us that a weak base will become ionized. It will pick up a proton and become positively charged in an acidic environment.
Okay.
And once a molecule is charged, it cannot cross cell membranes easily. It gets stuck.
It walks into the room, puts on a heavy winter coat, and suddenly it can't fit back through the door it came through.
That is the perfect analogy. Now, where in the body do we find compartments that are more acidic than the blood? 2 key places are the prostatic fluid in men and the vaginal fluid in women.
Ah, so trimethoprim floats out of the blood and into the prostate, which is acidic. It gets ionized, and then it becomes trapped there.
Exactly. It means the concentration of trimethoprim in prostatic tissue can be several times higher than the concentration in the blood. This makes it a premier drug for bacterial prostatitis.
Which is notoriously hard to treat.
Notoriously hard because so many drugs just can't penetrate that gland effectively.
And for vaginal infections, same logic applies.
Same logic. So, knowing the BK, the acidity constant of the drug, helps us predict where in the body it will work best. It's a really powerful concept.
But let's flip the coin on this. We flooded the body with these drugs. What is the consequence? What is the cost? The toxicity of sulfonamides is, well, it's legendary in medical history.
It really is. We have to start with the most common one, which is hypersensitivity, the classic sulfa allergy. Pretty common, and it usually presents as fever, a rash, itching. But we have to talk about the catastrophic end of that spectrum, Stevens-Johnson syndrome, or SJS, and toxic epidermal necrolysis, TMD.
This is the nightmare scenario every clinician worries about.
It is the nightmare scenario.
Yep.
SJS is a type IV hypersensitivity reaction. It's not just a simple rash, it's a detachment of the epidermis from the dermis. The skin blisters and literally sliss off.
Wow.
And it affects mucous membranes, the mouth, the eyes, the genitals. It can be absolutely devastating, and it can be fatal.
And this can happen to anyone who takes it.
It's idiosyncratic, which means it's hard to predict, though we are finding some genetic markers that increase risk. But looking at our patient, Mrs. G, if she had a mild rash to a sulfa drug in the past, giving her this drug again could potentially trigger SJS.
So you have to ask.
You must ask about the nature of any past reaction. I got an upset stomach is a world away from my skin started peeling off.
Right. Huge difference. Okay, let's talk about the kidneys.
Yes, the kidneys. Sulfonamides are excreted in the urine, but you have to remember your solubility chemistry.
Like trying to dissolve sugar in cold tea versus hot tea.
Exactly like that.
Yeah.
Sulfonamides, particularly the older ones like sulfadiazine, have pretty poor solubility in acidic environments. So if the urine is acidic and concentrated, the drug precipitates out of solution.
It turns into solid crystals.
Crystalluria. These are sharp, microscopic shards that form right inside the renal tubules. They can cause bleeding or hematuria, intense pain, and they can physically block urine flow, causing an acute kidney injury.
How do we prevent that? What's the clinical move?
Two simple things. First, dilution. Tell the patient to drink liters of water. Keep the urine flowing and dilute. Second, chemistry. We can alkalinize the urine. By giving the patient sodium bicarbonate, basically baking soda tablets, we can raise the pH of the urine. Sulfonamides are much, much more soluble in alkaline urine.
That's fascinating. So we have the acid trap helping trimethoprim concentrate in the prostate, but acidic urine is actually hurting us by causing the sulfonamides to precipitate. The pH works both ways.
Pharmacology is always about balance. And there's one more specific toxicity we should mention, G6PD deficiency.
This is a genetic enzyme issue, right? Common in certain populations.
Yes. Glucose 6-phosphate dehydrogenase deficiency. It's common in people Mediterranean and African descent. This enzyme is critical for protecting red blood cells from oxidative stress.
And sulfa drugs cause oxidative stress.
They do. They're oxidizing agents. So if you lack the shield, which is the G6PD enzyme, and you introduce the weapon, the oxidative drug, the red blood cells just burst. They lust.
Hemolytic anemia.
Acute hemolytic anemia. So for Mrs. G, we'd glance at her demographics and her history. It's unlikely at 59 that she wouldn't know she has it, but it's a mental checklist item you have to go through.
And very briefly, because it's such a distinct and important point, the issue with AIDS patients.
Yeah, this is a tragic irony. As I mentioned, patients with AIDS desperately need TMP-SMZ for pneumocystis. But for reasons we still don't fully understand, it's likely related to glutathione depletion in their cells. These patients have a massive rate of adverse reactions.
Oh, massive.
We're talking fever, rash, and leukopenia in up to 50% of AIDS patients taking sulfa drugs, compared to maybe 5% in the general population.
That is a staggering difference. It makes treating PCP a real tightrope walk.
A very difficult one.
Yeah.
Now let's bring all this back to Mrs. G. She's taken TMP-SMZ before, and it worked, but she's having a recurrence. Resistance to TMP-SMZ among E. coli, which is the most common cause of UTI by far, is rising alarmingly fast.
How fast?
In some parts of the U.S. and the world, 30% or even more of community E. coli are resistant.
So there's a 1 in 3 chance, or worse, that the drug just won't work. And she has a kidney infection, pyelonephritis, where treatment failure could lead to sepsis. We just can't gamble.
You can't. You need a bigger gun. You need a drug that is reliably bactericidal, that penetrates the kidney tissue well, and that doesn't rely on the folate pathway at all. You need to attack the DNA structure itself.
Enter the fluoroquinolones, the floxacins, Cipro, Levo, Moxie. These are the heavyweights.
They really are. And the history here is fascinating. The ancestor of this entire class is a drug called nelidicous acid, which was discovered back in the 1960s as a byproduct of chloroquine synthesis. It was what they called a urinary antiseptic.
Meaning it only worked in the pee.
That's exactly what it means. It didn't reach high enough levels in the blood or in the tissues to treat systemic infections. It was weak. But then, in the 1980s, chemists did something brilliant. They added a single fluorine atom to position 6 of the quinolone ring.
And that one fluorine atom changed the world.
It revolutionized the pharmacokinetics. I mean, it was a quantum leap. Suddenly, the drug could penetrate into every tissue, bone, prostate, lung, even the brain, and it had massive potency against a wide range of gram-negatives. That fluorine atom gave us ciprofloxacin.
So how do they work? We said something about untangling the DNA.
Imagine bacterial DNA. It's a massive double helix, but 1,000 times longer than the bacterium itself. To fit inside that tiny cell, it has to be supercoiled, twisted up, incredibly tight.
Like a rubber band, you keep twisting and twisting until it knots up on itself.
That's a great analogy. Now, when the bacteria wants to replicate its DNA, it has to unzip that double helix. But think about what happens when you pull the strands of a braided rope apart in the middle. The twist gets tighter and tighter at the ends.
Right, the tension builds up. If you keep pulling, eventually the rope will just snap.
Exactly. So nature evolved an enzyme to handle this tension. DNA gyrase, which is a type of topoisomerase 2. This enzyme is like a molecular pair of scissors with a built-in repair kit. It grabs the DNA ahead of the replication fork, it cuts both strands, it passes the loop through the gap to relax the supercoiled tension, and then it glues the strands back together.
It's like a tension release valve. Cut, relax, seal.
Cut, relax, seal. Perfect. Quinolones bind to this DNA gyrase complex. They jam the mechanism after the cut has been made, but before the seal can happen.
So the DNA is just left cut, broken.
Yes. The DNA is left fragmented, the chromosome breaks into pieces, the replication machinery stalls, the cell detects this massive, irreparable damage, and it triggers apoptosis cell suicide. It is rapidly bactericidal.
That is violent and very effective.
It is. Now, in gram-positive bacteria, the primary target is often slightly different. It's another enzyme called topoisomerase 50.
And what does that one do?
Its main job is to separate the two daughter chromosomes after replication is finished. They're linked together like two rings in a chain.
So topophorus is like cutting the umbilical cord between the two new cells.
Exactly. And quinolones jam that enzyme too,
Right.
preventing the separation. The bacteria can't complete its division.
So we have this powerful weapon, but there are different generations, right? I feel like this is where students often get confused. How do we categorize Cipro versus Levo versus Moxie?
Yeah, the generations thing can be confusing. I prefer to group them by their evolution of spectrum. Let's call ciprofloxacin the gram-negative sniper.
The sniper. I like that.
Cipro is the king of gram-negatives. It has excellent activity against all the Enterobacteriaceae, and, crucially, it is the most potent oral drug we have against Pseudomonas aeruginosa.
There's Pseudomonas again. So Cipro is the answer to that gap in the TMP-SMZ spectrum.
It absolutely is. But Cipro is relatively weak against gram-positives. It's notoriously bad at killing Streptococcus pneumonia. So if you try to treat a community-acquired pneumonia with Cipro, you might fail.
Okay, so chemists went back to the lab and created the so-called respiratory fluoroquinolones.
Exactly. Levofloxacin and moxifloxacin. These are the second evolution. They maintained good gram-negative coverage, though Levo is a bit weaker on Pseudomonas than Cipro is, but they gained massive ground against gram-positives.
Specifically strep pneumo. That's why they're called respiratory. They kill the #1 bacterial cause of pneumonia.
Correct. And they also hit the atypicals, things like Legionella, Mycoplasma, chlamydia. If someone walks into the emergency room with community-acquired pneumonia, levofloxacin covers almost everything on the differential.
Now, moxifloxacin. Moxie is kind of the rebel of the family. It behaves very differently in the body.
This is a critical clinical and safety point. Cipro and Levo are primarily cleared by the kidneys. They end up in the urine in very high concentrations. Moxie is cleared by the liver. It gets metabolized and ends up in the bile and feces.
So Moxie doesn't really go to the kidney or the bladder?
Not in any effective concentration. So here is the classic board exam trap question. You've never, ever used moxifloxacin to treat a urinary tract infection.
Even if the lab report says the bacteria is sensitive to it in the Petri dish?
Even then. Because the drug won't show up to the fight. It won't achieve high enough concentrations in the bladder to kill the bug. It's a pharmacokinetic failure. However, because it's not renally cleared, it's a good choice for patients with kidney failure because you don't need to adjust the dose.
That is the precision we talked about at the beginning. You have to match the drug's exit route to the infection's location.
Moxie has one other unique feature. It has modest activity against anaerobes. The other quinolones don't. So it's sometimes useful for mixed infections like intra-abdominal abscesses or aspiration pneumonia.
Okay, so Cipro is the gram-neg sniper. Levomoxie are the respiratory heavyweights. But there's a new kid on the block, delafloxacin. And this drug changes the science in a really interesting way that involves pH.
Delafloxacin is a real game changer because it addresses the acid problem. Remember how we said that abscesses and sites of infection are often acidic?
Yeah, plus dead tissue. It creates a low pH environment.
Right. Most of the other fluoroquinolones are zwitterionic. They have both a positive and a negative charge on the molecule. In acidic environments, they become protonated and more positively charged, which actually reduces their ability to penetrate bacterial membranes. They get weaker in an abscess.
So the harsher the environment, the worse the older drugs work?
In a way, yes. Delafloxacin is different. It's anionic. It lacks that basic group that can be protonated. This means that in acidic environments, it actually becomes neutral, which makes it more lipophilic. It penetrates bacteria better in acid than it does at neutral pH.
That is completely backward from the others. It actually thrives in the hostile environment of the infection.
It's incredible. It can be 10 times more potent at a pH of 6 than it is at a pH of 7.4 against some strains of staph. And it's also a dual targeter.
Meaning it hits both enzymes, gyrase and topoisomerase.
And it hits them with equal affinity. Cipro prefers gyrase, Moxie prefers topo4. Delafloxacin hits both with balanced high affinity. This makes it much harder for bacteria to develop resistance because they would need to mutate two different enzymes simultaneously to survive.
So delafloxacin is this broad-spectrum, acid-loving, dual-wielding super soldier. Why don't we just give it to everyone?
Cost is one reason, and stewardship is the other. If we use our newest, best weapon for everything, resistance will eventually emerge. We have to save for tough cases like resistant MRSA or complex skin infections where that acid stability really matters.
Which brings us to the consequence. Resistance. We thought we had the ultimate weapon with quinolones, but the bacteria, of course, fought back. How do they do it?
The arms race is relentless. The main mechanism for quinolones is target modification. The bacteria evolve point mutations in the genes that code for DNA gyrase. That's the gyrase gene, or topoisomerase, the parse gene.
So they just changed the lock so the key doesn't fit anymore.
That's exactly it. A single amino acid change in the binding pocket can reduce drug binding by 100-fold. And here's the really scary part. Cross-resistance.
Meaning?
Meaning if a bacterium becomes resistant to Cipro through this mechanism, it is usually resistant to Levo and Moxie too. You lose the entire class at once.
Wow.
There are also plasmid-mediated mechanisms. These are fascinating. The Q and R proteins. The plasmid codes for a protein that actually mimics the structure of DNA.
A fake piece of DNA.
A fake piece of DNA. This protein binds to the DNA gyrase and acts as a physical shield, preventing the antibiotic from getting in and binding. It's like a molecular bodyguard for the enzyme.
That is incredibly sophisticated.
It is. And on top of that, bacteria also have efflux pumps. These are literally sump pumps on their cell surface that recognize the drug and spit it back out of the cell before it can reach the nucleus.
Okay, let's bring all this back to Mrs. G. We have a 59-year-old woman with a complicated kidney infection. TMP SMZ is too risky because of resistance. A quinolone, let's say ciprofloxacin or levofloxacin, seems like the perfect choice for the spectrum and for kidney tissue penetration.
They are very strong candidates from a bug drug perspective. But wait, remember her breakfast.
The calcium supplement.
This is one of the most common and most preventable medication errors in all of medicine. Fluoroquinolones are chelators. They have a chemical structure that binds tightly to multivalent cations, things like calcium, magnesium, aluminum, and iron.
So if she takes her Cipro pill and her calcium pill at the same time,
they meet in her stomach and form a large, non-absorbable rock. It's an insoluble complex. The antibiotic is never absorbed into her blood. It just passes right through her GI tract and out the other end.
So she calls you 3 days later, she's getting worse, maybe septic, saying the drug didn't work, and your first thought is, oh, it must be a resistant bug.
But it's not resistance at all. It's a drug-food interaction. It's a failure of delivery. We have to counsel her explicitly. You must stop the calcium while you're on this antibiotic, or at the very least, take the antibiotic 2 hours before or 4 to 6 hours after your vitamins.
That single counseling point saves lives. Now, beyond that, are there other reasons we might hesitate to give her a quinolone? She's 59. She's active.
There are. And the FDA has added multiple black box warnings to this class for a reason. The big one is connective tissue toxicity. These drugs can cause tendinopathy and even tendon rupture.
The Achilles heel, literally.
Yes, the Achilles tendon is the most common site, but it can happen elsewhere. The risk is higher in older patients and in patients who are also taking corticosteroids. And it can happen days or even months after the treatment is finished.
And it's not just tendons, it's the aorta too, isn't it?
Correct. More recent data suggests an increased risk of aortic aneurysm dissection or rupture. The thought is that the same mechanism that weakens the collagen in the tendon might also weaken the collagen in the aortic wall.
Plus you have QT prolongation, which can mess with the heart rhythm and dysglycemia, causing wild swings in blood sugar.
Yes. So for Mrs. G, we have to weigh all of this. Is her infection severe enough to warrant these risks? Since it's pyelonephritis, a serious kidney infection, the answer is likely yes. The risk of sepsis from an undertreated infection outweighs the risk of tendinitis.
But if this were just a simple, uncomplicated bladder infection?
We would absolutely look elsewhere. We would try to spare the heavy artillery to save her tendons and her aorta.
Exactly, and that is the decision in broad-spectrum decision.
That's the art of it.
We've covered a massive amount of ground here. From the PBA decoy of the sulfonamides to the DNA freezing power of the quinolones. From the 1:20 ratio math to the acid-loving delafloxacin. How do we synthesize all of this for the listener?
I think the synthesis lies in the transition from what I call bug-centric thinking to system-centric thinking.
Can you explain that?
Sure. In the past, the main question we asked was, what drug kills E. coli? That's bug-centric. Now we have to ask a much more complex question. What drug kills E. coli but also penetrates the acidic tissue of the prostate, avoids being chelated by the calcium in the gut, and can be safely cleared by the patient's failing kidneys? That is system-centric thinking.
It's understanding the drug not as an isolated agent, but as an object moving through a hostile and highly variable environment, which is the human body.
Precisely. And understanding that broad spectrum is always a double-edged sword. The sequential blockade of TMP-SMZ is brilliant, but its broad use invites broad resistance. The DNA attack of the quinolones is incredibly powerful, but it can cause collateral damage to our own connective tissues.
There is no free lunch in pharmacology.
There is never a free lunch. Every potency has a price.
I want to leave the listener with that thought about delafloxacin again. The idea that we are now designing drugs not just for the bug, but for the environment of the infection, for the acidity, that feels like the future of antibiotic development.
It really is. It changes the taxonomy. Maybe one day we won't categorize drugs just by their chemical class, but by their environmental niche. This is the drug for low pH infections. This is the drug for anaerobic tissue. It's a fascinating evolution of the science.
Listeners, if you want to see the sequential blockade in action, I really encourage you to open Katsung and look at figure 46-2. It maps out that folate pathway visually. It makes that 1+1=3 concept click instantly.
And then flip over to Goodman and Gilman and look at the structural diagrams of the quinolones. Seeing that fluorine atom and the changes in the side chains really explains why the generations evolved the way they did. The reading is essential to lock this all in.
That's it for this deep dive. We hope you feel a little more precise in your power. Thanks for listening.